My name is Michael Shanik. I'm a practicing endocrinologist in New York, managing partner at Endocrine Associates of Long Island, and I have an academic title at Stony Brook University Hospital as Associate Professor of Medicine. I'm in a busy private practice and do a lot of clinical trials. It's a very common concern in our practice, seeing many diabetes patients, both type 1 and type 2. We see quite a bit of chronic kidney disease and certainly a spectrum of that, sometimes early on, capturing them, at the early stages, and obviously many times as it progresses and gets to the later stages. I think one of the biggest burdens certainly is for the patients, quality of life and concerns around that, and how much it involves much of their lives, especially when they wind up on dialysis. But even earlier on, we do know that there's a progression and association with other comorbidities, and certainly when we see patients with diabetes and chronic kidney disease, there's worse outcomes, there's a greater cardiovascular risk, and so on. So I think it has a huge burden, both medically and, of course, financially. Economic impact is huge. It's many billions of dollars per year on diabetes-related kidney disease. There's a great need for better ability to catch patients early, better ability to predict which patients might progress to advancing kidney disease. And there's certainly an unmet need because we really have very limited testing right now that can help us determine who might be at risk, especially early on, before we know the extent of which they might develop kidney disease. So I think that the need is there for sure to hopefully have better testing and capture these patients earlier. And I think that the environment that we're in now and the ability to manage patients with diabetic kidney disease is certainly improving. We have better treatments and others that are in development that might help with the standard of care right now. But I do think that there's a great need for better testing and better predictive models of how we can maybe slow the progression or hopefully impact future risk. Diabetes itself is a significant risk for kidney disease. And so because of that, I believe that if we have patients with, on a regular basis, coming to be evaluated and treated for diabetes, if there is a test such as PromarkerD, which might help predict as far as progression and prognosis, screening most patients with diabetes even before they have diabetic kidney disease might be helpful because we cannot at this time predict who's going to progress at a more rapid rate versus those that might remain stable for a while. For someone who might be moderate or higher risk with a PromarkerD test, one thing that I think would be very important is to be fairly aggressive when it comes to the management of blood pressure. Certainly the comorbidities that might contribute to the kidney disease, and also optimizing doses of various medications, which would include the ACE inhibitors or ARBs, and potentially incorporating SGLT2 inhibitors and possibly changing therapies in patients with diabetes, which we know might have other benefits aside from glycemic control. As far as how can a test help us manage our patients, I think the importance now when we have certain therapies that have benefits, cardiovascular benefit, renal protection, heart failure reduction, and so on, I think the collaboration between testing and outcomes is something that has not been looked at as extensively as I think we'd like to see. So I think that in the future, we're going to hopefully have a collaboration between testing and clinical trials and incorporating how a test might help predict which patients fare better, which ones might be better candidates for certain therapy. And as long as we're going along this line of what we determine is called precision medicine, trying to tailor therapy and hopefully decide which patients are best to be treated with certain agents, I think that's where the future of medicine is going.